The fascia iliaca compartment block is a regional anesthetic technique used as an opioid-sparing pain management strategy for hip fracture patients. With a single injection, sensation to the femoral nerve, lateral femoral cutaneous nerve, and obturator nerves can be blocked. This is done by injecting a large amount of dilute anesthetic into the potential space just below the fascia iliaca, lateral to the femoral nerve. Local anesthetic spreads along the fascial plane to reach these three nerves. I start by discussing the risks, benefits, and alternative pain management treatments with my patient and obtaining consent for the procedure. I then complete a pre-block scan to identify the sonoanatomy of the femoral neurovascular bundle. Remembering the naval mnemonic from lateral to medial, I expect to see the femoral nerve, artery, and then vein most medially. Lateral to the neurovascular bundle, I look for two hyperechoic fascial planes. Superficial is the fascia lata, and deep to this is the fascia iliaca. The ultrasonographic landmarks for injection are just deep to the fascia iliaca, lateral to the femoral nerve, and at the level of the common femoral artery before it bifurcates into the deep and superficial femoral arteries. This pre-block scan is a great time to adjust the ultrasound machine's depth and gain to optimize the image before donning sterile gloves. Once I have identified my landmarks, I prep the patient with 3 chlorhexidine sticks, draw up 30 cc of 0.25% bupivacaine into a 30 cc syringe, and put non-sterile gel on the ultrasound probe. I then open a package of sterile towels. Using the towel's packaging as a sterile field, I open a sterile needle and tubing, probe cover, and ultrasound gel. I am now ready to put on my sterile gloves and drape the patient with the sterile towels. Next, I place my hand inside the sterile probe cover and pick up the probe using the cover to maintain my sterility. Two rubber bands are then added to keep the probe cover secure. Finally, I place sterile gel directly on the patient and am now ready to scan the patient in a sterile fashion. While the fascia iliaca compartment block can be performed as a one-person technique, I prefer a two-person technique using an assistant. To set up my sterile needle, I hold the needle's tubing out to my assistant, who connects it to the syringe of bupivacaine and then flushes the line. In this way, the assistant has the non-sterile syringe to aspirate and inject, while I hold the sterile needle and probe to guide my injection. So if I'm scanning and I see two arteries, then I know I'm too far caudad. So if I scan cephalad, then they join together to become the femoral artery again. And then as I'm looking for two fascial planes. The fascial plane above sartorius is the fascia lata, and the fascial plane below is fascia iliaca. So I'm going to be aiming to inject just below fascia iliaca. I rescan the sonoanatomy, and after re-identifying my landmarks, I advance the needle using an in-plane technique. As the needle passes through the fascia lata and fascia iliaca, I can feel 2 pops representing each of these layers. I then ask my assistant to aspirate and inject 1 to 2 cc's while I watch the screen for hydrodissection. An anechoic pocket of fluid should appear just below the fascia iliaca, separating the fascial plane from the iliopsoas muscle laying just beneath it. Depending on where the anechoic fluid appears, I adjust the needle as needed to keep the needle tip in the potential space just below the fascia iliaca. Once I am happy with the position of the needle, I ask my assistant to aspirate and inject the remainder of the local anesthetic. After removing my needle, I apply a bandage and use a skin marker to write the following information on the patient's leg: the time, date, and type and volume of local anesthetic. This helps to prevent a consulting physician from repeating a nerve block directly after I have performed one. I ask my nursing colleagues to monitor the patient's vitals at 5, 10, 15, and 30 minutes post-block. local anesthetic systemic toxicity, and relative opioid overdose after painful stimulus is removed by the block are rare but serious complications of the fascia iliaca compartment block that won't be discussed in this video. These topics should, however, be reviewed by providers using this technique clinically. Finally, I document my procedure in the patient's chart using a tick box form available in our emergency department. Special thanks to Dr. Erin Slonwhite for her help recording this video.